Hello everyone, thank you for coming. Welcome to this session of Nato's 36th Annual Conference. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. Now I will turn the stage over to Charles Hawley, Nato's Director of Projects.
Thank you, Maura. Thank you everyone for being here. I'm excited to introduce this panel discussion on killing fee-for-service to save rural health. Let me quickly just say thank you to all of our sponsors and remind everyone you can take a look at those pages on the left of your screen, stop by, get game tokens, that sort of thing. And without any further ado, I will introduce Şule Gerovich of Mathematica. She's the Senior Director of State Health Policy, and she will be moderating today's panel. Hi, Şule.
Good morning and good afternoon, depending on which time zone you are. Thank you for joining our panel discussion. If you were expecting a murder mystery based on our title, I'm sorry to disappoint you, but we have great panelists who are on the ground implementing a very innovative model for payment reform. So what we are going to do is we are going to have them introduce themselves quickly, and then I'll have a set of questions to ask them around the murder mystery, and then we'll have questions from the audience at the end. So with that, let's start with Janice and then move through the order. Janice?
Sure. Thank you, Şule. So I am Janice Walters. I've been serving as the Chief Operating Officer to the PA Rural Health Program, which you're going to learn a little bit more about today. This program was originally birthed through the Pennsylvania Department of Health, and I joined the initiative when it was in the Pennsylvania Department of Health. And it has since the program's moved to the Rural Health Redesign Center, and I continue to serve in the Chief Operating Officer capacity, overseeing its overall implementation, which includes the methodology development, recruitment of stakeholders, and oversight to the transformation planning process. So thankful and happy to be here today.
Thank you, Janice. We have the partner in crime, maybe Gary first, and then we'll go to Jim.
Sure. Good afternoon, all. This is Gary Zegiestowsky, and I am the Executive Director for the Rural Health Redesign Center. I have been with the organization since we were originally formed back in June of 2020, and the model had progressed a few years before that, as Janice will reference, as she talks some, but I am new as we formed the new organization to take over leadership of the model going forward and the evolution of that in Pennsylvania. So looking forward to sharing more about what we're doing in Pennsylvania and how we see the future of global budgets going for the model we're driving here and helping the rural residents of PA.
And we have a representative from the hospital provider side. Jim, would you like to introduce yourself next?
Sure. Thanks, Şule. Welcome, everybody. And again, good morning or good afternoon, depending on where you are. My name is Jim Pettinato. I am the Director of Patient Care Services for Wayne Memorial Hospital in Honesdale, Pennsylvania, kind of in the upper northeast corner of the state. We're a 106-bed facility, 92 acute beds and 14 rehab beds. And we're a level 4 trauma center, primary stroke center, and we also operate a cardiac cath lab under the exception by the Department of Health because we do not have an open heart backup team, but we participate fully in all the cardiac emergencies. My job responsibilities, I oversee all of nursing, social work, pharmacy, home health, hospice, utilization review and case management. And I'm also a board member for the Rural Health Redesign Center. And thanks to Janice, I'm sitting here today as our hospital was one of the first-year hospitals. We were one of the first 5 in the state to actually join in the model when Janice was first entering into that role with the Department of Health. So welcome, and hopefully we can offer some good information here today.
Thank you, Jim. And last but not least, from the peer community, we invited Doug Doyle. Doug?
Hi, my name is Doug Doyle. I am the Senior Director of Provider Network for Gateway Health. Gateway Health is a Medicaid, Medicare government really sponsored program for the state of Pennsylvania. We have about 330,000 Medicaid lives across the state and another 60,000 DSNP members. So we primarily focus on the neediest members of our community. I've been within the rural health redesign model for 2 years, or at least we're finishing up our second year with Gateway Health, and I am also a board member. Thank you.
Awesome. Thank you so much. So before we get into the details, as the title suggests, the program decided fee-for-service was crux of the problem in rural health. So I wanted to give opportunity to Janice to explain a little bit more what the program is and what we are trying to do in Pennsylvania. Janice?
Yeah, sure. Thank you, Şule. So, at the heart, and what we're doing within the confines of the Pennsylvania Rural Health Program is fundamentally changing how rural hospitals are paid. So we are divorcing ourselves from the traditional or historical fee-for-service payment mechanism, where we all know hospitals are paid based on the volume of services provided. And we're actually moving hospitals within our program to an all-payer predictable payment model. And in exchange for that predictable payment, we are asking our hospitals to really focus on transforming the healthcare delivery system within their communities, focusing on population health and quality of care. So we all know my background prior to joining this was in hospital leadership, financial leadership of a rural health system here in the state of Pennsylvania. And so I certainly understand that from a strategy perspective, most leaders, as you're putting your strategic plan together in fee-for-service, you're really focusing on volume of services because that is how you're paid. And that's not a criticism, that's just a reality that as business leaders, we tend to build our strategies based on how we're paid. And so if we really want to move and incentivize, population value-based, we need to basically change the fundamental way hospitals are paid for. And that has a dual benefit for rural hospitals because we're looking to sustain hospitals. We all know that fee-for-service is not a viable strategy for rural hospitals into the future because you need a lot of people, a lot of demographics within a community to make a volume-based payment mechanism work. And so we're looking to provide predictable revenue to hospitals so that, as leaders of our hospitals, they know what their revenue is going to be so that they can plan for the business. But in exchange for that, our payer community is asking them to commit to transformation. So we really want to focus on, what does the community need? Our hospitals most of them are required to put together community health needs assessments. And we really feel like within the confines of our program, we align that payment with the need of the community. So we have really two pillars of our program. I like to call them pillars. The first is the global budget, which is the predictable payment, divorcing ourselves, murdering fee-for-service, as Şule has cleverly, coined this session, providing a predictable payment. But equally important is what we call the transformation plan. And that's really the strategic plan of how the hospital is going to start to invest in, I would say, community benefit and really focusing on the needs of the community. That community health needs assessment is a key input into that. But what are they going to do in exchange for that global budget to actually improve the health of the populations they serve, as well as improve quality of care and access to care in rural communities? So, most hospitals, they don't get into it if the finances don't work. But, once in the program, really the transformation is, I think, the secret sauce that in exchange for that global budget, how do we work in partnership with our payers? Because as I stated, this isn't all payer. We're looking to get the majority of a hospital's payment covered under the global budget. So we have representative, not only hospitals, but payers on our panel today, but we have all of the predominant payers within the state of Pennsylvania participating in our program, which is really what the hospital needs in order to take their focus on volume and really move to value. So reducing avoidable utilization. If you think, well, what does transformation look like? Our overarching goal is to identify avoidable utilization within these hospitals. And what can we do in partnership with the payers in the hospitals and us serving as model administrators to really identify avoidable utilization, keep people out of the hospital that don't need to be in the hospital, really build outpatient services, and make sure that the appropriate care is provided in the appropriate setting. So in a nutshell, that's what we're trying to do.
And there's a 120-page document explaining the whole the terminologies and the methodologies. So doing that in a couple minutes. Thank you, Janice, for that high-level summary. So Gary, do you have anything to add? I know rural health has been a forefront in a lot of policy discussions nationwide. We are seeing rural hospitals closing, sometimes abruptly, sometimes in a long suffering trajectory. Anything else you want to add in terms of the motivation and why we are doing this model in Pennsylvania?
Yeah, a few things, and thanks, Şule. I think first and foremost, we believe that the model has the ability to help us improve the health of the residents in rural Pennsylvania. And as Janice mentioned, we're focused not only on keeping the hospitals open with, a financially stable position, but really shifting focus to align the care delivery capabilities of these hospitals to meet the needs of these communities. We have a lot of chronic conditions. We have a high level of substance abuse. So there's a lot of things that we're trying to address in terms of what are the challenges in rural America that the model is focused on. And this is a CMMI demonstration. So we're trying to prove, can this work as a financial model, but also as a model to truly address a disparate population, being rural geographies in general. Just to give you a little sense of the disparities and the magnitude, in terms of rural Pennsylvania, we have 18 hospitals, roughly 18 communities. The poverty rate for rural Pennsylvania is about 12.8%. Ours is 13.7%. The unemployment rate for rural residents in Pennsylvania is 4.2. In our communities, it's 5.5. So not only are these disparate communities in general with high poverty, high unemployment, and disability and illness, but the communities we're serving are actually even more disparate than the averages for the state. So the goal is really to find solutions to help these residents. And now that we have 18 hospitals in the model, we have about 750 million in net patient revenue. We are touching just over 1 million lives in these rural areas. So we see now not just to prove a demonstration for CMMI that can this work to help improve healthcare in rural areas and make it sustainable, but also can we make this scalable and truly transform healthcare for more communities in Pennsylvania in the rural areas, as well as build something that could potentially go beyond Pennsylvania. So that's really what our motivation is. And I think the other dimension to keep in mind is in these communities, not only keeping these hospitals open is critical to care, but it is critical to the economic viability of these areas. Most of these communities, the hospital is the first or second largest employer in the community. So having that hospital closed not just impacts care, it impacts the viability of these communities overall. So we believe we can make a difference on multiple fronts by being successful with this model and continuing the focus of what we're doing.
Gary, so you mentioned the CMMI. So CMS obviously invested a lot in the last 10 years to move the system to value-based care, implemented several different initiatives. So Pennsylvania is one of them, which is implemented at the statewide. And I think the first model really focusing on rural health. They have accountable care organizations and bundled, and now they are trying to narrow it down to a few promising models, which rural health is one of them. I want to turn to Doug a little bit. So we know the CMS's motivation and the CMMI policy goals. Doug, do you want to kind of talk about from the commercial payer perspective, like why you are in this model and what it means to you?
Sure. So I've been in Pennsylvania for 30 years in the healthcare industry. I'd like to ask Janet how many years she's been in, but maybe I shouldn't. So I was thinking back when I was preparing to speak today about the landscape 30 years ago as it is today. I mean, in the landscape 30 years ago, I was working with Humana for their network expansion at the time, and the landscape was focused almost solely on community hospitals, independent community hospitals. They were everywhere. They had great golf outings, by the way. But I mean, no matter what community you would go into, there'd be a hospital there. And 30 years later, I mean, as we look at the print, there's not a hospital in every community. And some communities where there is a hospital, that hospital is owned by a larger health system, rather than just that hospital is basically a feeder to the tertiary care centers, and not a community resource, not somebody who's there focused on what the community need is. And it's a very different environment. So as I mentioned in my introduction, Gateway Health Plan is Medicaid, Medicare, primarily Medicaid. I mean, when we take on the responsibility as a fiduciary for the state, we take on a responsibility for our members having access to care. And on a daily, I mean, I'm in network, on a daily basis, we deal with access to care. I mean, whether it be a facility closing OB services, I mean, that impacts the health plan, it impacts the community, it impacts the provider. But I mean, if somebody can't afford to offer obstetric services, we have to start to look at a health plan as to what's the alternative. I mean, our members are receiving care there. I mean, is it 20 miles? Is it 30 miles? Is it 40 miles? I mean, our clinical folks have to work on that. And behavioral health. I mean, the Medicaid population has behavioral health needs, as does the DSNP, as does commercial. But what if we don't have access to that behavioral health? How do we service that member? How do we create opportunities for that member to receive care and to improve, to get better? And we saw a steep decline in access to these services. And so we started talking to Janice at the state level and determining whether or not we were going to participate. And we started to look at the mission. And I mean, as time has gone on, I said it earlier, we're 2-year participants. I mean, we've seen the transformation plans. I mean, we've seen what these community hospitals want to accomplish, and quite honestly, it's right in line with what we want to. And there wasn't necessarily dialogue between Gateway Health Plan and Wayne Memorial to determine what Wayne Memorial's transformation plan was going to be. But whenever Gateway Health Plan would see Wayne Memorial or see Mon Valley or see Washington, the participants see their transformation plan, it almost perfectly aligned with what we determined were going to be the needs of our members. So I mean, if we can follow through, if we can capitalize, if we can implement these transformation plans, our members, our Medicaid members, are going to receive a higher level of care than they would have in the fee-for-service environment. I mean, if we would have continued on the path, as I said, to 30 years ago when I started, to the 30 years now, if we would have continued on that path for another 30 years, quite honestly, you may have had to drive 140 miles to deliver a baby, which is not sustainable. I mean, that's just not appropriate whenever we're trying to service the needs of our Commonwealth and of the country as a whole. I mean, we can't have those situations present themselves. So we're all in. I mean, we're through the transformation plans. We're through the acceptance that the providers are going to start to focus, or have focused, but now have the funding to focus on the areas that are going to service our members. Now we're kind of in the phase of data sharing, communication. I mean, some of these hospitals, quite honestly, I might not be communicating with. I might not be looking at their data. They might not be looking at our data. We might not be meeting quarterly. I mean, as I say to Janice and Gary all the time, I mean, for those of you that are familiar with value-based care, we've taken providers who would have never been able to participate in a large health plan value-based arrangement and basically put them in one. I mean, they're getting the same data as our value-based people. They're getting the same needs assessments as our value-based providers. I mean, so these rural hospitals who quite honestly may or may not have had a seat at the table now do, and now we're recognizing what we can do collaboratively and what data we can give them and how they can act on that data. And the funding is the easy part. I mean, there was never a question on our side as to whether or not the funding was appropriate. That was a slam dunk. I mean, there's not a penny that we've put into this program or a commitment to maintaining cash flow for these facilities that we regret. So really, I mean, the funding's the easy part. Now, understanding where we need to go to service these communities and understanding the collaboration between the payer and the provider that is going to enable us to get there is where we are now. And I'm very encouraged that we're going to be there. So thank you.
Thank you. So Jim, what do you think about the model, and what was the most exciting thing from your perspective?
Well, I have to say, the most exciting thing from my perspective, again, my base being a clinician, my second role as the administrator for the programs I'm responsible for here, was really the transformation from being a sick care system to being a true healthcare system. Obviously, the old model of fee-for-service, you know, when you pull in the parking lot in the morning, our CEO would say, a full parking lot is a good day at the hospital. And that whole concept of changing that, you know what, an empty parking lot could even be a better day at the hospital, meaning that people weren't necessarily being hospitalized or utilizing a whole lot of hospital services, particularly for those that were probably in an inappropriate utilization. So truthfully, the most exciting part for me was to make that transformation from being sick care to really focusing on promoting health. And obviously to do that, you know, we needed good data. And the enticing part, when the Department of Health and team came in here and literally stickered a conference room of posters with our data, our patient outcomes, how we were looking at ambulatory sensitive conditions in our emergency room, the number of maybe avoidable admissions that were going through our inpatient departments, it was truly eye-opening. And that, you know, that small, and really not small, large chunk of data, but that one small encounter at an opening visit caused our administrative team to really kind of take a deep breath, look at what was put before us and go, gee, you know, we may have thought we were doing a good job, and we were doing a pretty good job as a sick care system, but boy, as a true healthcare system, we weren't exactly maybe hitting all the marks that we needed to. And frankly, that was a real challenge for us to acknowledge that, because when this model came forward, we had already been in what was the Keystone Accountable Care Organization for about 2 years, 3 years. I forget the actual time frame now, but we were in long enough to start getting feedback, and in the ACO models, really trying to focus on health and promoting health, promoting primary care visits, getting people hooked up with primary care physicians. And we kind of really thought we were hitting the mark, and getting the data back and seeing on the ambulatory sensitive conditions and seeing on the avoidable hospitalizations, we realized we had a lot more work to do. And while we were, again, getting data through our ACO, the data being provided to us at that point through the Department of Health and the claims information, which predominantly was Medicare, it really kind of opened our eyes. So it was kind of exciting then to be able to take Janice's 2 pillars and say, how do we build on this, and what can we do? And that was really the start of the transformation plan for us in the areas that we needed to look at, and, you know, to kind of really hone it in a little more. Obviously, we're all faced with the same challenges: the social determinants of health, the uninsured, the indigent population, the rural community challenges of just transportation, housing, food, clothing, shelter, anything that was common. So when you look at it and you kind of go, my gosh, it can't possibly take all this on, we wanted to take on a challenge that was going to be effective at addressing, again, our ambulatory sensitive conditions, but also the inappropriate utilization. And like any small hospital, our ability to manipulate large portions of data is very limited. So part of the rural health model is really helping streamline some of those data communications, getting the information back to us in a usable fashion. There are some challenges to that, which I think we'll cover later, but in our journey, we were able, through the rural health model initiatives, through the transformation plan, really come out with 2 major areas of concern. One was in our food insecurities, and we went ahead and pursued an entire program that helped us address that matter. The other was the focus on behavioral health. And while our ACO reports and any of our internal reports, you know, reviewed diagnoses, reviewed chief complaints and reoccurring visits, what we were able to kind of do through the model is identify that behavioral health was really kind of the driving force back, and in particular diagnosis areas, particular age groups. It frankly wasn't a deep dive that we had taken before, and I know that may not sound like, oh wow, that's really not new information, but it was very pointed information, and it helped us focus our limited resources as to what the corrective action needed to be. And while we were trying to address ambulatory sensitive conditions and inappropriate utilization, the real answer was we needed to kind of beef up particular areas of our behavioral health program that were significantly impacting our emergency department and inpatient stays. So again, with limited resources in rural communities, being part of the model really kind of helped us focus what limited resources we had into those areas. And obviously those are not easy transitions. Those things don't, those actions and initiatives don't change things overnight, but we do feel really good about the fact that we are beginning to make an impact. We are making a difference in some folks' lives, and we're hoping that that continues to grow, and we take on the next challenge going through. So again, exciting for us because it kind of brought forward a weakness or opportunity for improvement, and through the rural health model and transformation plan, really get some in the weeds focused initiatives that are really going to put some meaning on the table and change the way we deliver healthcare.
Great comments, Jim. Thank you so much. The prior session talked about using data for value-based care, and one of the questions is what is the use of data and how we can make it useful. I think your comments really speaks to the heart of how we can use the data to make change on the ground. And the audience and the Nato members, our intersection is using data for policy, and we have a lot of passionate both state and the local and private sector members right now who are really thinking through how we can make the data more useful. So maybe we can open up a little bit more and have Janice to comment what kind of data the program provided to providers. And after that, we can talk about some of the challenges that Jim mentioned, and maybe others could also chime in.
Yeah, sure. Thank you, Şule. So just to say, one of the probably biggest challenges that we had and still have is the exchange of data. And we all certainly understand the need for good data to drive decisions. And so that's one of the things as we talk, more broadly in terms of the applicability. And when we get questions from other states, one of the things that I like to point out is make sure you have your data sources available at the beginning. We've had to build a lot of that infrastructure within our program. And certainly that's not ideal, but we've made it work, thankfully. But yeah, at the beginning, as Jim mentioned, we really did try to provide hospitals with a starting point. So, before you can tackle a problem, well, you kind of have to understand, well, what's the starting point? And if I'm going to start a journey, where's a practical way to start the journey? And so, as Jim pointed out, we really tried to provide to them the Medicare claims data. So as we talk about avoidable utilization, it's kind of a big, scary term. But at the end of the day, it can actually be mapped, to diagnosis codes, et cetera. So using claims data and various algorithms, some of our methodology is piggybacking on work done in other value-based programs, even Maryland's global budget. And so we're using pretty much standard definitions of what we would consider avoidable utilization. And so really pulling out of the claims data, out of, the past experiences of the hospitals, to actually, as Jim articulately showed, we could provide evidence of the opportunity to them as they consider joining the program. So really claims-based data at the diagnosis code to actually show, what diagnoses are driving your avoidable utilization. I think one of the things that Jim hit on that's a little bit more difficult is the behavioral health. Because a lot of times people will come into your hospital with a clinical diagnosis that makes its way to the claim, but you can't really get behind maybe some of the social things or some of the behavioral health things that are driving, so it's the way you get that is by engaging with the patients. And as you start to engage with the patients, you learn about the patients and can then help to address their needs. But at the beginning, it was really claims-based data. And we continue to build that out along the journey. We're working with our commercial payers. So we provided to our potential participants CMS data because that's what we had available. We would love to evolve that to where we're providing our participant hospitals the same level care organization. To date, Pennsylvania claims database. We don't have a robust HIE. Us, we've had to build a lot of this infrastructure. But we're now to the point where we're also providing our hospitals get a comprehensive HEDIS look of their participant community once a year, bringing in aggregate payer data, so commercial payer data, aggregating that for the participant community and sending that back, because each payer has its own plan. Each payer has its own product. Medicare has its own. And so how can we actually aggregate that and give our hospitals a comprehensive view of how they're doing with certain HEDIS metrics within their community, and to also help monitor our program? We've also built out for them dashboards. Jim's informed me they're not as pretty as what we originally presented to him, but we have built out dashboards that do show more current information. So in working with our CMMI partners specific to CMS, they can see the diagnosis codes that are still driving their utilization. And then our hospitals also have the ability to get the underlying Medicare beneficiary data to actually support those higher level dashboards. So it's been an evolutionary journey. I'd love to say we've got all of the data issues solved. We don't. It really does continue to be one of the pain points. But certainly, listening to our hospitals, understanding what type of information they believe they need, and then working with our payer stakeholders, whether that's our MCOs, such as Doug's representing here today, or Medicare specifically, really, I would say being that advocate for our participant hospitals to ensure that they have the data that they need to effectively administrate and be successful in this program.
So I'm monitoring the chat, and maybe I'll ask a question which is very relevant right now from Imelda Flores about the performance and quality matrix the model is using. Janice, you mentioned HEDIS measures, avoidable utilization. Anything else that you want to add in terms of specific matrix we're using?
Yeah, so we do have certain metrics, really trying to piggyback on existing reporting. We all understand that our rural hospitals are already strapped from a resource perspective. And so really trying to piggyback on infrastructure that's already in place to monitor the program. So, readmissions, my opinion of readmissions is, the easy work's already been done. And, the readmissions, a readmission rate of 0 is not necessarily appropriate, because there are some people that actually do need to come back into the hospital for care, et cetera. But, readmission rates, ambulatory sensitive conditions. And so really monitoring, the ambulatory sensitive conditions, as well as ED avoidable utilization. We really believe that for most of our hospitals, it's ED avoidable utilization where the predominance of, I would say, opportunity lies, as well as ambulatory sensitive conditions. And then we're also tracking some substance use. So one of the goals of our program is to increase access to care. And so we're using some HEDIS measures there, but also reduce the deaths associated with substance use disorder. And so using some HEDIS measures, as well as some NCQ metrics, et cetera. I think that's the right acronym. Forgive me if it's not right. But really trying to use industry accepted methods and metrics that are already, whether they're in a CMS value-based program or whether it's a commercial HEDIS value-based program that maps to Medicare Advantage, really trying to leverage the quality reporting that already happens as part of the claims system. And being able to tease those metrics out versus reinventing the wheel. So happy to share more specifics on that, but really what we're tracking is what you would expect to see in a value-based program. Readmissions, ambulatory sensitive conditions, ED utilization, and then various access and, like I said, substance use disorders, to really try to hone in and reduce deaths associated with substance use disorder.
Thank you, Janice. So part of it is, as you mentioned, there is no all-payer claims database, but you were able to manage a multi-payer, almost all-payer model without a lot of regulatory power, right? So it's a voluntary program. Doug mentioned why the commercial payers joined, and Jim is kind of putting the hospital perspective on it. But you were able to kind of manage that lack of all claims-based database by producing standard reports from other payers. So I wanted to see if Doug, you can talk about the implementation side of it and what challenges you see from the data perspective as a payer participating in a volunteer program for rural health.
Yeah, I mean, the managed care organizations have the data. I mean, that's just the reality of it. I mean, we have line of sight on what the community hospitals provide because we have the claims data and other sources of data. They have no line of sight on what happens whenever that patient, whenever that member to us is not within their system. So, I mean, you talk about avoidable ED. They can only look at avoidable ED within their ED. But if somebody's going to another ED, they don't have line of sight on that. And as Janice said, our Pennsylvania HIEs leave a little bit to be deserved at this point. I think there's too many in the market, and until we can consolidate and have some consensus of using one or two, we're probably not going to get there. So we can provide that data, behavioral health data. I mean, some of our community health provider or community hospitals don't have behavioral health services, or people are going outside of their network to receive them. So if somebody has severe prevented mental illness, SPMI, our community hospitals may or may not be aware of that. So they may be looking at, hey, we have this patient or member who comes in a lot, but we might know their behavioral health activity outside of their network. So I really do think the responsibility is on the managed care organizations who have the whole line of sight on the entire care continuum for the community-based members that these hospitals are serving to provide that to them. I mean, challenge, there's 184 hospitals in our network. I think there's like 193 in the state of Pennsylvania. So we have our larger hospitals that there's a financial interest in us to work with them because there's a bigger slice of the pie that's assigned to them. So where do we go? We have the larger hospitals, we have the community hospitals. There's a whole continuum in between. So we just need to find the resources. I mean, we need to get the data out. We need to get it, as James said, James, usable. I mean, these community hospitals are smaller, less staff, IT departments of maybe 3, 4. I mean, so us sending them data that they can mine through and that they can use is difficult. But I think, I mean, Gateway Health is trying to take on that responsibility, trying to give them usable data that they can make decisions on a daily basis. But like I said, I off the top of my mind, I think we have maybe 10, 11 participants within the rural health model. These larger institutions where we have a bigger financial stake, the middle ground of the 184 hospitals. So we need to figure out the resources that we can garnish to get these guys the data that they need. So that's kind of what we're working through. But we have meetings with the providers and data requirements being board directed at this point. I mean, so as a participant in the program, we've committed at the board level to provide these guys, these community hospitals, with the data they need to succeed. So we got to follow through on that commitment from our board and from our leadership and figure out how to do that and figure out how it can be ingestible and usable. So that's a challenge that we have, but we're ready to work through it.
Great. So Jim, before I get to your perspective on some of the other challenges around data, there's a question about the participation with large national payers from Richard Slusky. Have the large national payers, Aetna, Cigna, United, indicated a willingness to participate in a global budget program? And is CMS prepared to pay hospitals without reconciliation based on cost and shadow billings? Who would like to take the question?
Since nobody's jumping or raising their hand, I guess it's me.
Go ahead, Janice.
You want me at the top?
So the answer is yes to the first part. Aetna is actually in our program. And so we're very pleased to say Aetna has brought all of its products, commercial, Medicare Advantage, and Medicaid managed to the table for our participant hospitals where it makes sense to do so. So we do have some thresholds because there is administrative burden with administrating this program, both at the plan and the hospital level, and there's also risk. And so we want to make sure that for both parties, it makes sense. But yes, Aetna's at the table. United was fully engaged. We were onboarding, and then COVID-19 happened. So I'd be remiss to say we're doing all of this in the midst of COVID-19. And so certainly that the pandemic has impacted our program. And certainly one of the areas that it has impacted was, United, given everything else going on, did not continue onboarding. As it relates to Cigna and some of the other ones mentioned, we don't have a predominance of Cigna currently in our rural communities. And so we've really assessed who, we have scale targets that we're looking to meet. We're trying to get as close to 90% of a hospital's net patient revenue as possible covered under the program. And so as we looked at, revenue cycle and other publicly available information through organizations such as, PHC4, here in the state of Pennsylvania, really identified the payers that we felt we needed to bring to the table to reach that threshold. So we have had outreach from other interested payers, but right now there's just not sufficient, I would say, levels of payment in these communities that would actually make sense. So we're trying to take a very methodical and data-driven approach to who we recruit to the program. And, with the exception, if COVID-19 would have happened, I'm pretty confident that United would have been with us as well. But Aetna is being a good partner in the program. Specific to CMS and their willingness to pay global budgets without reconciliation based on cost or shadow billing. So very important to say, while we have critical access hospitals in our program, we have not interrupted the critical access hospital methodology. And so those hospitals that are in our program are still cost-based reimbursed. Some people might say, well, then what's the benefit for the critical access hospital to be in this program? There still is benefit because we do take that cost-based reimbursement and provide it in the form of a predictable payment. And so every 2 weeks, our hospitals know what their payment's going to be. And one critical access hospital leader within a few months of joining the program said to me, I no longer worry about making my payroll because I know my Medicare global budget will cover my payroll. And so that's a pretty strong, critical access hospitals cost-based reimbursement is still tied to fee for service. And so you have to still bill the claim to get the per diem for the inpatient stay or the percentage charge reimbursement. So if you've got seasonality fluctuations, that really still does impact the critical access hospital. So the predictability of global budget certainly is benefit to our hospitals. And in addition to that, I like to point out in the state of Pennsylvania, our program, or the state of Pennsylvania specifically, is really heavily managed Medicare. And so cost-based reimbursement only provides protection to the critical access hospital to the extent they have fee-for-service Medicare volume. And so what we've seen in the state of Pennsylvania is, the benefit of the cost-based reimbursement actually be eroded over time, because Medicare Advantage plans are not considered, part of that cost-based reimbursement. So the benefit to the critical access hospital really comes back to what's your payer mix. And if you have a high level of, managed Medicare, our program does provide benefit because we calculate the global budget, the methodologies that we apply to the global budget, et cetera, are, you've got Medicare fee for service, but then all of the managed care products, so whether it's commercial, Medicaid, or Medicare, are all treated the same way. And so there's definitely a global budget benefit to the extent you have a payer mix that supports, payer participation because you have a smaller volume of Medicare fee for service. So certainly benefits, to participation for even cost-based organizations. And then specific back to shadow billing, I just want to, be clear here, because I'm not quite certain of what the term or what the implication of the question is, but, we have not interrupted the revenue cycle processes at all. And that's really, really important because what's covered under the global budget is the payer's portion of payment to the hospital. You still have your co-payments, your deductibles, your self-pay amounts, et cetera. And so in order to be able to facilitate that, we have to keep the claims process intact. And we're also using that claims process to pull in a lot of the quality information that I talked about. So we still need the claims to go in. But as far as a reconciliation back to claims-based fee-for-service, we're not doing that. And I like to say, if at the end of the day, back to fee, we're still service. You are paying it different, but we truly are going back to the title of what we're talking about today, trying to divorce ourselves from fee-for-service, build a new mousetrap. And so, reconciling back to fee-for-service activity, we certainly use fee-for-service activity within our global budget methodology to do some of our calculations, because there's really no other way to assess shifts in market, etc. But really reconciling back to cost or fee-for-service holistically outside of the critical access hospital is not part of our program.
Thank you, Janice. So reconciliation is one of the challenges I think, Jim, you might touch upon as we get the data. We talked about the data to help the transformation plans, but there's also the financial place where there are some adjustments done to the global budgets reflecting market shifts, etc. So are there any lessons learned or challenges that you want to bring up as the program moves to a more mature state?
Sure. I think the one thing which really, there's really not probably a better solution right now. And, we need to allow the 3 months claims run out, on any of this data that we're collecting, just because of the processing time. And again, while we're looking to maybe make some more immediate changes when we're trying to direct care of someone who's in our facility, the hope is with the beginning of this data exchange that's going on with the payers, that we can get beyond eventually some of just the claims information and really network with the payers and not duplicate efforts. If they already have maybe a person enrolled in their case management or their intensive case management programs, and now the patient's presenting on our doorstep, to know and get that information and have that readily available, I think is probably something we're working towards. But right now, again, solely relying on claims information, there is the run out period. As far as the reconciliation piece goes, I think some of the challenges vary among the payers. Some payers have not included all of their programs in the rural health model, and there's a division within the insurer themselves about what programs are in, what programs are out, which makes it very difficult because even at our hospital IT system level, for example, Insurance X, they might have had 50 plans, but every time any of those 50 plans presented to the hospital, we put in the insurance as Insurance X. And there wasn't necessarily good maybe separation prior to really trying to look at a deep dive into a particular payer's programs to make the reconciliation match up. So they have Plan A, Plan B, Plan C, Plan D, whatever it is. But again, in our hospital information system, we recorded them all as, Insurer A. So trying to get those reports out internally and reconciling have been a bit of a challenge. So of course, in some respects, we're going backtracking. I think the insurers too, I probably leave more to Doug's comments and the challenges they have within their payers. But, I'm in these insurers side too, deciding which programs are in and which ones are not, because this was a voluntary program, was clearly a challenge, a little different than the Maryland model where it's kind of all in. So it took that kind of ambiguity maybe out a little bit. But I think a lot of good headway has been made. Recognizing what the roadblocks are and the challenges have been will help us trying to streamline that data, not duplicate efforts in caring for patients, and hopefully get a little more timely information going forward.
Thank you, Jim. So we don't have much time. So in the interest of time, I want to kind of shift a little bit. Janice mentioned COVID. If it wasn't COVID, other payers would have joined. Given that this is providing some predictable revenue, you could already kind of see the value of this model. But how did COVID impacted you, Jim, and Doug from payer perspective by being in this program?
I can answer really quickly and let you know that if we were not in this program, our hospital is the only hospital in a 2-county area. We took a large influx of folks from the New York and the New Jersey area into the northeast corner of Pennsylvania because people left the big cities to get away from COVID because they were the hotbed areas. Unfortunately, many came here infected, and we took a real brunt for a small community hospital of probably a third to, on some days, half of our inpatient census of the size hospital we are being COVID. And had we not had the financial stability coming from the monthly installments from the payers, from CMS, we would not have been able to shut down elective procedures, shut down our surgeries. Obviously, for any hospital under a fee-for-service model, more business, more money, allows you to kind of keep the lights on. We could safely allocate and reallocate resources, both financial and human resources, to caring for the pandemic patients, as well as the other patients that were not pandemics, because the heart attacks, the strokes, and everything else still didn't go away. But they weren't obviously taking on elective cases. We didn't have a whole lot of other hospital admissions. We would not have made it through COVID and caring for people the way we did if we had to worry about the monthly income statement and our fee-for-service payments. We looked at PPE that cost 400 to 500% more than what it would have cost us prior to March of last year. Double rates of agency nurses to bring in additional staff and support, not to mention compounded by what would have been financial losses with the shutting down by state mandate of elective surgeries. So it was just a recipe for disaster without the rural health model.
Yeah, when the model was envisioned, we never expected such a pandemic and impacting hospitals to this extent. Gary, anything else that you're hearing from the hospitals, or how COVID is now changing the way that you're thinking about the model?
Well, I think one of the things, as part of the CMMI demonstration, NORC did an evaluation that's posted out on the CMMI site. And, I think one of the big points that they highlighted is that the global budget was really a lifeline to these hospitals from a financial stability standpoint, as Jim mentioned, during the pandemic. I think more broadly, no hospitals in our model closed during COVID, and that was also a challenge with some across the country, given the stop of fee-for-service revenue and trying to absorb all the patients with COVID. So I think from a financial standpoint, it really was a great demonstration of the value of the model and one of our tenets to provide that financial stability. I think more broadly, it highlighted the criticality of keeping hospitals open in these rural communities, given the need for care in a proximate geography in scenarios such as a pandemic, where access was a very important component to meet the needs across both your urban and your rural communities. And especially with hospital capacities being, very high across the state of Pennsylvania, as they were everywhere at different stages, the necessity of keeping the doors open and keeping as many hospital beds available as possible was viewed as imperative. I think the other part of it, which was a byproduct also mentioned in the NORC report, is while some of our transformation plan efforts to improve care were delayed during COVID because of the focus on the pandemic, some were accelerated. Obviously, telehealth, which was an area, especially in rural healthcare, that we're focused on expanding to improve access, especially with limited resources, limited specialists, et cetera. But that went from 0 to 100, as it did in many places, that has put telehealth in a much stronger position to support rural healthcare going forward as part of the model. So I think there was, a lot of different things that COVID impacted that set a stage going forward that pointed to a lot of what we're trying to accomplish as core things that make sense and our value components to keep going in the future.
Thanks, Gary. There is a question from Stefan Gildemeister around the document that I mentioned, jokingly 100-page. To the extent that some of the information is available, can you post a link? I was I was referring to a technical document, which is for the data programmers to run the claims. It makes a great bedtime reading, in my opinion, but the NORC report might be a good one for you to get a better sense of, at high level, how the model is implemented, what data sources are included. But if you need more information, anyone on the call, Janice, me, or Gary, will be happy to talk with you, Stefan, about the details. So we have, I believe, 5 minutes left. So in the remaining time, please feel free to add your questions still. I'll do my best to put them in front of the panel. As we are waiting for those questions, I guess looking from where you've been and where you are headed, what are the priorities for each of you as we move to a more mature model and kind of solve some of the issues that you mentioned, especially around data?
Would you like me to take that first, Şule?
All right. Sorry. Yeah, I'm doing a very bad job. Janice, why don't you start first?
That's okay. Yeah, I mean, in my opinion, where we're at now is really execution and executing well. So, you know, this has been a 7-year journey. We're about halfway through. The first 3.5 years really was about building. We have built. We have recruited hospitals. We've recruited payers. We've built data infrastructure. And we still have not overcome all of the challenges, as you've heard today. But, you know, we have spent 3+ years building, and now it's time to really execute. And so I'm really excited in terms of that execution, you know, and building out the data analytic capability to really, you know, we understand, as I said, you know, we've wrapped up recruitment. We have 18 hospitals. We know the communities that our program is now in. We know the payers that we're partnering with. So how do we really leverage the data as has been, you know, discussed here, and really help that drive transformation to achieve, you know, the outcome measures that we're going to be judged upon. So as Gary mentioned earlier, you know, we're in the midst of a test. I like to remind everybody, we are testing something. We're in the middle of a model. And so now the last half is really going to be focused on execution, performing well to actually impact, you know, the metrics that we've identified, that we've said we're willing to be judged upon, whether we've achieved our goal or not, and really focused on implementation, executing well to actually improve the health of the people that reside in these communities. Because at the end of the day, this is really about people. And making sure that the people in each of these communities have, you know, access to the care that they deserve, and that, you know, will actually hopefully keep them well or improve their health over time. So that would be my perspective of where we're at.
Anyone else wants to add in 1 minute? I have one more question to ask Doug after that.
So it's just, Jim, I think, you know, building on what Janice said, the structure is there. I think it's down now into a grassroots effort of the individual hospitals working with the individual payers to really make inroads that through the open communication that's now been established, as Doug said, small places may not have had a seat at the table. We need to take advantage of that seat at the table now and really see how we can impact our individual transformation plans for the greater good.
So Doug, the question to you is about the from Imelda Flores. Do you have them in your plans, and how do you make sure you coordinate care with Medicare?
Yes, we are fully Doyle eligible. So we don't really have that responsibility. So our members aren't part of alternative Medicare programs. So we do not have any Medicare Advantage population. We have 50,000 Doyle eligibles. I mean, we have coordination with Medicare, but not at the patient care level.
And they are part of the Medicare global budget, so you kind of split in a way. The budgets for Doug's plan comes from the Medicaid side of the business, and the Medicare portion comes, and it's really up to the hospitals. You know, Jim, as the provider, now has the full incentive to manage those populations and look at their avoidable utilization for care coordination. So it is done at the provider level rather than at the plan level.
Right. Correct.
All right. Okay. I think that's kind of concludes our session. If 1 minute early, but I work with you, you know, quite frequently. But this has been great. I even kind of learned and kind of thought about different perspectives of this model, despite my day-to-day involvement with the program. So I really appreciate your perspective and what you brought. I hope the audience took good notes and have other questions. So feel free to reach out to us, any of us. And thank you again for joining the panel and spending 1 hour of your precious time. I know, Jim, you are on the ground with COVID and everything. We really appreciate all of you joining for the panel.
No
Thank you as
problem.
well.
And I think I'm going to be able to get a golf ticket to Doug for next year because he said he loved the golf matches in the small hospital. So, Doug, I have a ticket with your name on it.
I'll be there.
Thank you all. It was fun. Thank you.
Yeah.